Thanks a lot, Graham. Thank you for asking me to speak at the conference today. I think we should be able to shed some light on the threat posed by prostate cancer and give you all a bit more certainty about that. So how do we? All right, so to understand how to manage prostate cancer, urologists need to understand the natural history of the disease. And this is the time course of the disease as it would play out without any curative medical intervention. We understand this, and then we can advise men on the likely course of the disease and therefore the potential benefit of early intervention. Now, prostate cancer is usually diagnosed rather late in life, when men are at an increased risk of other diseases, other threats to their life, in particular cardiovascular disease. And these, as a group, these diseases are referred to as competing causes of mortality, and they may affect the length of a man's life. So we need to weigh the risk of the prostate cancer up against the other threats that are present. This is a picture of Willett Whitmore, a famous American urologist who stated eloquently when he said that growing old is invariably fatal, while prostate cancer is only sometimes so. Two familiar faces. A lot of urologists and radiation oncologists are emulating these two guys, in my opinion, in their approach to low-risk prostate cancer. Tenzing and Hillary knocked the bugger off because it was there. And my argument today is that just because low-risk prostate cancer is there, and it's often there, that it does not necessarily need to be knocked off, and however rewarding that may be for the clinician. We now know, and you know, that through widespread PSA screening, that a large number of low-risk cases are found, cases which pose a minimal threat to the well-being of the patient, in contrast to the high-risk cases at the other end of the spectrum, which pose a much more significant threat to the man. We're looking harder for prostate cancer nowadays than we ever have, and that's because the age of biopsy is dropping. The PSA thresholds for biopsy are lower than they have been, and also the extent of biopsy is increased. So all of these factors have increased the rate of diagnosis of very small, very low-grade, low-threat disease. So active surveillance, first and foremost, involves risk assessment. Active surveillance is identifying and watching the turtle, the slow-moving, minimally threatening cancer, and distinguishing it from the bird and the hare. The bird is the fast cancer, poorly detected by screening and likely metastatic already by the time of detection. The hare is the cancer that is localised at detection but possesses the ability to metastasize. And these are the cancers that we can potentially cure. In deciding upon management, we need to convey to the patient, through good communication, the threat that their disease is to them. And usually for low-risk disease, the threat is actually much less than either the patient or the doctor realise. And the reason for this is, of course, because of the slow-growing nature of many prostate cancers and the large role that competing causes of mortality play, which is most relevant for older men with low-risk disease. So what is the natural history? What happens if we do nothing? Well, Peter Albertson, a urologist from Connecticut, was one of the first to publish data on this. He followed nearly 800 men diagnosed with prostate cancer in Connecticut during the 70s and 80s. Now, this was the pre-PSA era, so patients generally were diagnosed very late compared to these days with PSA. Larger volumes of tumour and generally more active tumours than we see today. And these guys were not treated with any curative therapies, simply hormone therapy if they became symptomatic. So we can see from this data what happens over time to this group of men. And the chance of dying of prostate cancer related strongly to the speed of growth of the cancer as assessed by the pathologist under the microscope and the age at diagnosis. Men with low-risk disease had a very modest risk of progression, even over periods as long as 20 years. And this is shown in the top 2 rows of that slide, which are for slow-growing prostate cancer. Even after 20 years, the chance of death from prostate cancer, which is the dark grey band, is still 10% or less. The competing causes of death far outweigh that of prostate cancer, and that they're in the light grey band. The bottom 2 rows show that for faster growing cancers that the chance of death, the dark grey band, is quite high when you follow it over a 20-year period. So it's this understanding of the natural history which allows us to advise patients on the potential benefits of treatment versus monitoring. Now this data was accumulated in the pre-PSA era. We now have a 10-year lead time bias through PSA testing. So 10 years can probably be added to the numbers there for contemporary patients. So now we understand the natural history, we can counsel an individual on the threat that might be posed by his prostate cancer. And there are 3 major disease factors which are associated with prostate cancer death. The PSA level at diagnosis, the local tumour stage assessed by digital examination and sometimes MRI scan, and the Gleason score of the biopsy. You've probably all heard of Gleason score. It's simply the pathologist's assessment of the speed of growth of the cancer cells seen in the biopsy. Once we've established those disease factors, we need to evaluate the patient factors, which have a bearing on longevity. And this is really a best guess at how many years the patient may live for after accounting for physiologic age and the competing causes of mortality. Integration of the 2 parameters, disease factors and patient factors, help the patient and the urologist decide on the threat that the cancer poses. And once we're clear on that, then a meaningful discussion about management options can be undertaken. Making the decision about which course to take involves weighing up the potential advantage of curative therapy in terms of the magnitude of the potential for reducing disease-related harm and the disadvantage of the treatment-related toxicities. And once this exercise has been done, it's one of 3 management options which can be pursued. Surveillance with a view to cure in the future if there's evidence of disease progression, and this is termed active surveillance. Or we can watch with a view to administrating androgen deprivation therapy if the disease progresses to a point where it's symptomatic or likely to become symptomatic in the near future, and that is termed watchful waiting. And finally, the curative therapies of surgical removal of the prostate or exposure of the prostate gland to radiation. Watchful waiting is an option for elderly men generally who have other serious disease threats, such as heart disease, and are unlikely to live long enough to derive a benefit from curative intervention. It's men who usually have a life expectancy of less than 10 years, and Peter Albertson's famous graphs allow us to predict, depending upon the speed of growth and the age of the man, what may happen to a man managed in this way. And we generally see a fellow on watchful waiting once or twice a year with a PSA level a couple of times that year. And if symptoms arise, or once the PSA begins to generally go past 20 or begin to exhibit quite a fast rate of change, then hormone therapy is begun. And hormone therapy suppresses testosterone, which is the anabolic hormone which the testicles produce and which is a growth promoter for prostate cancer. So when we use this, the cancer goes into remission, usually for several years. It's not a cure, however we know it slows the disease course and is very good at reducing symptoms. Active surveillance. is a management strategy to delay or avoid curative therapy without compromising long-term cancer-specific survival. So in order to put the curative strategies into perspective, we need to look at what benefit the curative therapies offer men with prostate cancer. What exactly is the magnitude of benefit of having curative therapy? And it's best to look at that by breaking localized prostate cancer down into two groups, the low-risk cancers and the higher-risk cancers. For higher-risk cancers, there's more to be gained from treatment because the risk posed by the disease is greater. In terms of the magnitude of the threat in higher-risk disease, we can look at a famous Swedish trial comparing simple observation versus treatment, which was conducted in the era before widespread PSA testing. Nearly 700 men with predominantly higher-risk cancers were randomised into either watchful waiting or surgery, and this was updated this year. With a median follow-up of 18 years, there was a difference in the death rates from prostate cancer between those two groups. It was an 11% difference. 17% died of prostate cancer in the watchful waiting group versus 20% in the surgery group. Now this was a landmark trial, the first to ever show a benefit of treatment over simply watchful waiting. When we look at which patients in the trial benefited from treatment, we see that it is the men in the intermediate risk group. The graphs on the left show the surgery patients, the graphs on the right, the watchful waiting patients. The dark green section shows death from prostate cancer over 18 years of follow-up, and it's broken down into low, intermediate and high risk cancers. Men with low risk cancer did not have a significant difference in the risk of dying from prostate cancer, and interestingly, in this study, nor did the men in the high risk group. Remember, this is pre-PSA era data, so many of the men in the high risk group were super high risk, and they probably had micrometastatic incurable disease. So when we look at higher risk disease, the threat to health and longevity is considerable and more imminent. So men are more prepared to accept the risk of morbidity for a chance at cure. The scales tilt towards curative therapy rather than active surveillance. For lower risk disease, it's becoming increasingly clear that the risk posed is very low, much lower than we thought even 10 years ago. In the European randomised study of screening for prostate cancer, which I think you've probably heard about already today, the benefit of PSA screening was driven by the high-grade cancers. Patients with low-risk disease, in fact, had no survival benefit, even amongst the youngest patients aged 50 to 54. Now, this study is out to 11 years, and that might be too short in young patients with low-risk cancers to show a survival difference. The second Swedish study looked at men aged under 70, diagnosed with low to intermediate risk prostate cancer between 1997 and 2002, and they linked the diagnosis to the cause of death register. 70% of men had curative therapy and 30% active surveillance. When we look at the 10-year risk of dying of prostate cancer in this study, we see that in the surveillance arm, it is just 2.4%, very similar to the figure of 2.7% in the curative therapy arm. Men were in fact nearly 10 times more likely to die of another cause during those 10 years than from prostate cancer. And finally, the PIVOT trial, a North American randomised trial of surgery versus observation for localised prostate cancer. It's quite a similar study to the original landmark Swedish study. However, it has an important key difference, which is relevant to typical contemporary patients. And this is that the study was performed in the PSA era, where we had the advantage of detecting cancers earlier at a smaller stage. The cancers were predominantly low grade in the study rather than higher grade. 700 men randomised to surgery or observation and then followed for 10 years. The death rate at 10 years was 5.8% in the surgical arm versus 8.4% in the observation arm, and that wasn't a significant difference. When subgroup analysis was done, this suggested that surgery might reduce mortality among men with higher risk cancers, but not among men with low risk tumours. And the forest plot there, not sure how well you can see it from the back of the room, but it shows an advantage for higher risk disease, but not for low risk disease. So these findings, the studies that I've mentioned, support observation rather than treatment for men with low risk localised prostate cancer. And the pendulum or the scale swings towards surveillance rather than treatment. And indeed, this is what has been happening worldwide as evidence for active surveillance for low-risk disease mounts. This is data from my hospital here in Wellington. Two of my registrars, Matt Page and Daniel Marshall, put this project together and presented it at the Urological Society meeting in Brisbane earlier this year. We've compared two time periods, 2006 to 2009 versus 2010 to 2013. Active surveillance as a proportion of management strategies for low-risk disease is represented by the blue segments. Over that time, there's been a significant increase in the proportion of low-risk patients managed with active surveillance at the expense of the curative therapies. And this trend is mirrored internationally. These graphs show the proportion of low, intermediate and high-risk cancer managed with surgery over time. The top graph is from Memorial Sloan Kettering Cancer Centre. It shows the change in management of prostate cancer in that institution over the decade from 2000. The solid line in the top graph shows the fall-off in surgery for low-risk disease and also a rise in surgical management for high-risk disease, shown on the grey line. And the graph for my unit in Wellington is shown below and looks very similar. So what is the evidence for active surveillance? Well, the evidence is all observational data. This year, a systematic review of the best active surveillance series was published in the Journal of Surgical Oncology. 10 series were included in the review, which contained 3,500 men and had an average median follow-up of 4.5 years. The inclusion criteria varied a little between the studies. However, the majority of men in them were low risk, as defined by PSA under 10, Gleason score 6, and organ-confined disease on rectal exam. Some of the programs included some men with intermediate risk disease. And patients were monitored in the usual fashion with a combination of repeat biopsies, PSA measurements, and clinical examinations. All the programs used an upgrade in Gleason score as a criterion for progression and recommendation for treatment, and some included an increase in the number of positive cores. PSA kinetics were used in 7 of the programs and clinical progression in 5. So this table looks at the 5 and 10 year probabilities of stopping active surveillance, and at 5 years it was 33% and 10 years 55%. After stopping, most patients went on and had curative therapy with an even distribution between surgery and radiotherapy. In terms of survival, the 10-year prostate cancer specific survival is reported between 96 and 100% for this group. That's for both low and intermediate risk cancers. This slide is from the largest study of active surveillance by Laurie Klotz. The 10-year prostate cancer survival is 97%, and the chance of death from a competing condition is 18.6 times that of prostate cancer. So I've focused on the positive aspects of active surveillance in this talk so far, but of course there are some unanswered questions and concerns. It's quite a new management style for prostate cancer, and in general the questions we have are: who should we select, how should we monitor them, and what should the triggers be for intervention? There are concerns that the initial biopsy may not truly represent what's occurring in the prostate. We know that approximately 1/3 of men who go forward for a rebiopsy or have surgery for their low-risk disease are found to have more extensive cancer on the final analysis. However, after the first rebiopsy, the annual risk of progression is much lower, just 1%. There are concerns about the morbidity of biopsy, not least the risk of serious infection, but also repeat biopsies causing scarring and potentially making future surgery more difficult. We have a problem with PSA. It's not as good as we used to think it was in terms of monitoring men on active surveillance. There are definite limitations of PSA in that respect. The first active surveillance cohort was published over a decade ago, and since then an increasing number of publications have emerged. We know that active surveillance in selected patients is feasible, with an estimated 10-year cancer-specific survival of 96 to 100%. However, the long natural history of prostate cancer has to be borne in mind. Longer follow-up of these studies are necessary before definite conclusions about reduction of over-treatment and survival outcome can be made. In the future, I think we'll be using more MRI scans. MRI has advanced recently, so that not only can we look at tissue, but we can look how tightly packed the cells are, which is referred to as diffusion-weighted imaging. We can look at how blood flows within the tissues after contrast is given, and that's referred to as dynamic contrast and enhanced MRI, and also the chemical makeup of the tissue. And together those varying techniques are referred to as multi-parametric MRI. And they can help us differentiate between high and low risk cancers. They can help indicate whether the cancer is intracapsular versus extracapsular. So use of multi-parametric MRI, I think, will allow better selection of active surveillance patients, a reduction in the number of biopsies, which would be very helpful, and it should also help us more accurately identify progression of disease. So concluding, we can say that active surveillance reduces over-treatment of low-risk disease, which is a major concern with prostate cancer, without compromising 10-year survival. Our current selection and monitoring tools are rather imprecise, and we know that imaging might have a larger role in the future, and we certainly need to follow up the current cohorts for longer before we can make definite conclusions about the future role of active surveillance. Laurie Klotz sums it up pretty well. He's really the father of active surveillance, Canadian urologist. He says that active surveillance is a practical middle ground between radical treatment for all, which results in over-treatment of patients with indolent disease, and watchful waiting with palliative treatment only, which results in under-treatment of those with aggressive disease. Thank you. Are there any questions?
Hang on, we'll just get the microphone.
Okay.
I've just got a very, very simple question is, do you monitor what actions the patient actually goes through? Is there a lifestyle change when people know that they're under active surveillance? Or, is there data growing on that?
Do people change their diet?
Once they know that they're on active surveillance, do they change their diets, the exercise regime, anything like that?
We certainly encourage them to. I turn the conversation around often and say, well, we know you've got a little bit of slow-growing prostate cancer, but believe it or not, that's not the biggest threat to your life. It's still actually cardiovascular disease for most men. You're still more likely to die of something else. So it's all about living longer, and the best thing most men in this age bracket can do to live longer is to reduce their cardiovascular risk profile through good cholesterol control, low blood pressure, regular exercise.
Thank you.
Yeah, the mic's coming.
Thanks for your address. You identified low risk as PSA under 10 and Gleason score under 6, but you didn't identify what you call immediate risk and high risk. And related to that question, active surveillance really relates to low risk prostate cancer and some in the intermediate group. Is that
Certainly, yeah.
right?
Yeah, that's right. So there are various risk measures. Most of us use the D'Amico classification, which is PSA, finger test, and Gleason score. High risk is Gleason higher than 7, PSA over 20, or a tumour which we think is extra prostatic.
Oh, sorry, just one other question while I'm holding this. You mentioned the improvements in MRI capacity and the multi-parametric MRI. Is that available in Wellington now, those sort of MRI scans?
They are. It's really not a different machine, it's just a different software and the use of some contrast at the time of the MRI.
Right,
Yeah.
okay, thank you.
Yeah.
Given that it appears in several of the discussions that MRI seem to be beneficial, why don't they use more often than establishing from the start how developed the cancers are?
Well, the role for MRI is growing, particularly with the multi-parametric techniques that we have. In fact, it's even the case that sometimes we're ordering them before a biopsy to counsel a man on the likelihood that that biopsy might or might not be positive, and also to help target where the biopsies are taken from. There are some areas within the gland which are hard to get to with a needle through the transrectal route, and sometimes a transperineal approach is better, particularly for cancers at the front of the prostate. So certainly the role for it's expanding. It's an expensive test though. It costs up to $2,000 for a scan, so using it prior to biopsy would have financial implications, and I don't think we could advocate that. But it's certainly for certain selected patients, doing it earlier in the disease course is very reasonable. And in active surveillance, it's often part of the first year of testing. At the end of the first year, often I'll do an MRI prior to that planned second biopsy. Okay.
Yeah, one more question. The third speaker now has stated that there are limitations with PSA. We're out there at the coalface as people are working with and trying to get people to present to a doctor if they have any symptoms. What element of confidence do you think we now have that, most people don't carry around a portable PSA counter, and you certainly won't be able to afford an MRI scan. So, the difficulty we've got, we're trying to encourage people to come forward, and yet in the media and out there are all these doubts that some of these procedures these people subjecting themselves to are not universally supported by the medical profession.
Yeah, I think PSA is unique in that it allows us to give a man an idea of his risk of prostate cancer, and most cancers don't have a blood test that allow us to do that. So that's a good thing. But if you've got a tool, you need to know its limitations, and certainly in the screening realm, that's where PSA performs the least well. Further down the algorithm, once you're into prognostication and follow-up after treatment, it performs much better. It's a much better test in that setting. We're always on the lookout for better tests.
Can I just follow that up? The balance we've got to look at is that someone presents before it was tested, because the impact and the work that we have to do is support people for somebody who's at that stage is far greater than getting a person who's under sensitization, if that's the right word.
Sure.
Very, very difficult.
Look, I think it's a very useful test, without a doubt. But the critics would say, and they're right, that it's led to a lot of over-treatment. And we need to pull back from that. And that's where active surveillance is so compelling. We can identify cancers early, but once we've identified them, we need to leave a lot of them alone and really focus on the more threatening cancers and treat those ones, because that's where the money is. That's where the benefit lies for men in terms of curing cancer and making them live longer.